Excellent. Right. Well, we might make a start. Good evening, everyone, and welcome to tonight's webinar, Dementia and End-of-Life Care in Regional and Remote Victoria, Care Planning and General Practice. My name is Emily Buchanan, and I'm the Primary Care Projects Lead at Western Victoria Primary Health Network. I might move to our acknowledgement slide. Thank you, Claire. I'd like to begin by acknowledging the traditional owners and custodians on the lands and waterways from which we're all joining in from today. We recognise diversity, resilience, and the ongoing place that Aboriginal and Torres Strait Islander people have and hold in our communities. We pay our respects to elders both past, present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. I wish to extend that respect to any Aboriginal and Torres Strait Islander people connecting in today. Thank you. This evening's event is the first of a series of quarterly webinars for general practice with a theme of quality of life focused care and support for patients, their families and carers. Through this webinar series, we aim to support general practice staff to navigate palliative care and end-of-life care systems. This webinar series forms part of a palliative care quality improvement in general practice initiative that's been undertaken by the 3 regional primary health networks. That's Murray, Gippsland and Western Victoria PHNs. The aim of the work is to try to improve timely identification, response and management of patients living with life-limiting illness. We're seeking interest from general practitioners and other subject matter experts to contribute to the localisation of a palliative care quality improvement toolkit for regional Victoria. In June, general practices from across regional Victoria will be invited to participate in a 12-month quality improvement outreach activity using the localised toolkit. Practice facilitation will include support to redesign care systems, to embed quality of life focused care strategies, and to generate data-driven continuous improvement practices using quality improvement incentives. I'd now like to briefly introduce you to the PHN members of this collaborative. So from Gippsland PHN, we have Project Coordinator for Palliative Care, Helen Page. If you'd like to give us a wave, Helen, thank you. From Murray PHN, we have Vitor Rocha, our Palliative Care Lead. I'd like to give us a wave, Vitor, hello. And we also have Veronica Denton, who is our Palliative Care Project Coordinator, also from Murray PHN, who's unable to join us today. And myself from Western Victoria PHN and my colleague Katrina Pilbeam, who's our Primary Care Project Consultant for Western Victoria. Thank you all for joining us to say hello. So we might, this evening's webinar will be recorded and it will be available to view on the Learn PHN YouTube channel, and a link is going to be put in the chat for you to access this. And many of you will be familiar with Health Pathways, the free online resource with localised clinical and referral information for health providers. We've included links to each of the Health Pathways landing pages for Gippsland, Murray and Western Victoria, as well as some specialised pathways for dementia care and resources that have been developed through the Dementia Pathways project. So just briefly, some housekeeping for this evening's webinar. We're going to keep all participants will remain on mute, but if you have questions, we encourage you to add them to the Q&A box, and I will be presenting these to our presenter on your behalf towards the end of this presentation. There's also a link in the chat box to the evaluation survey, and we'd really like you to complete that following the session, please. You can either follow the link to access the survey or the QR code, which you see on your screen at the moment. All right, I'm very pleased to introduce our presenter for this evening's webinar, Dr. Claire Hepper. Dr. Claire Hepper is a GP in Creswick, where she was born and raised, and where her solo GP father, Dr. Brian Hepper, worked for 43 years. Building on the community medicine lessons her father taught her, Claire is a GP with special interest in palliative care and compassionate community work. Although now working as a solo GP, she has 13 years experience working in a group practice and managing a large local residential aged care facility with a dementia specific wing. Claire is happy to provide her slides, all digital resources, and to be available to answer questions in the future to support regional and rural GPs. I'll hand over to you now, Dr. Hepper. Thank you.
Thank you, Emily, and thank you to our 3 wonderful PHNs who have made this happen tonight, and very, very appreciative of them giving me their time to speak, even if I'm talking gibberish at you, and I apologise. I am a bit croaky. It's not COVID again, I promise. It would be just hay fever, very windy around here. We hope the internet will stay up to it. Now, I will preface my talk by saying I've gone for functional rather than pretty. So if you're someone who likes to sit back with that glass of wine and watch a very pretty presentation, you're in the wrong talk. But it has got a lot of resources, and Emily has touched on as well, there are a heap of resources out there. And we know that sometimes the information might not be something you need right now, but it's handy to know in the back of your mind, something happens tomorrow, next week, next month. Okay, I think I know where to go get that information. And that's what GPs, practice nurses, and our community are really good at. So I've got a QR link up there for a scan for the resources folder in Google Drive. We have discovered that some organisations will have a bit more firewall than others. So if you can't access the Google Drive link through that, email Emily or email me. My details are at the end of the talk, and I'm happy to get those resources to you in another format. I've put in red there to remind myself as well that there are some things that I might say that are my opinions only. And of course, we know not everything that we think is true, but this has just been my experience and how I found it for practicing in regional Victoria. I won't say rural because that's really cheeky, and we've got lots of big health services around us, so I'll say regional. And I understand I'm talking to GPs, GP registrars, practice nurses, people all across 3 different PHNs. So your local experience is going to be really important, and I'd love to hear how things are working in your area. What we say in compassionate community work is let's focus on what's strong, not on what's wrong, and then we can build on that. So if we get going, so the learning outcomes very quickly to discuss end-of-life care planning and the role of the GP. And improving that end-of-life care journey. I hate the word journey, but it's in there, so we'll go with it. Living with dementia. So just have a think about it. We'll go through it, but basically you need to know what you're going to offer and where you sit. And as a minimum, you need some resources. You need to know what your pathways are, and you need to know when you're out of your depth and you need to refer, which it all happens to us occasionally, but that can happen. Implement advanced care planning, and I'll tell you later why I hate the term advanced care planning. In general, practice consultations, enhancing care coordination and the management of palliative care needs. So you've got to understand the breadth of palliative advanced care planning and palliative care. Most people do, but it's still quite confusing for a lot of the public. So I think understanding that better will also help with death literacy for all of our community. So your minimum data set, you probably need to know what your resources are, where to get help if someone's got questions about advanced care planning that you can't answer, and understanding how to assess capacity, which is a really important part of what GPs do. And we get asked about it all the time, and just knowing that it's not an all or nothing question. And then the one that you've probably all joined in for, but I'm afraid I don't have too many magic bullets here, is outlining billing optimisation strategies for end-of-life care planning, palliative care focused general practice consultations. So I've got some resources on how to bill effectively. I've got some autofill links, and I've got some templates. They're all in the Google Drive folder, but we'll get to that. So I won't spend the whole start of the talk outlining what palliative care and dementia is, because when we do that, we run out of time and we've got a lot to cover. But there was an interesting article in News GP, which is RACGP's online bulletin, and it said help needed to navigate complex end-of-life care. So this is needed, that this is tough. It's not just a situational thing in your area. It's hard to understand. It's tricky all over the place. And sometimes services are provided by a health service. Sometimes they're provided by the council. Sometimes it's an independent body who does it. And who's who in the zoo is really hard to know. So this is just acknowledgement that it's tricky all over Australia. They do talk about 2 items there, which I will outline later, that I don't think it's something that GPs need to do, or even that needs to be funded. This is particularly the care coordinators and provision of service directories is something that can be done in the community with very little cost and really beneficial for your community. So I'll go into that as well. Not strictly what we're here to talk about tonight, but it will make your life better. We know as we go out further rurally, we have a lot more disease and demand, and we have decrease in our formal services. When we say formal and informal, it's the way different services are referred to in the literature. It's a bit cheeky. It basically just is more funded and unfunded, I guess you could say. So informal services, there's nothing informal about them. They just tend not to be funded. So they're your support agencies, your Lions, your Rotaries, your church groups, your school groups, your mum's group, you know, who's doing the work. So this is care planning in a nutshell, all right? These are your take-home messages. You can log off after this and disappear if you like, but these are the messages of know thyself, all right? So what is your role going to be as the GP registrar, the practice nurse? Are you going to be central to this discussion? Are you going to be peripheral, or are you going to be remote? And I'll talk about what that means, but know that first before you go into committing something with a family. We have to normalise the palliative approach. That's across all disease trajectories, not just dementia, but particularly important in dementia because it's not just a little bit of loss of memory. It's a terminal life-limiting illness, and we need to sort of gently get that out there. And that's part of getting that information in the community, increases the death literacy, and that will increase outcomes and improve outcomes for people who aren't sort of blindsided by palliative care coming in the last 2 weeks. Take a hint. So if someone says they're scared about the future, any GP registrar, practice nurse, social worker, OT, physio, anyone worth their salt, I know, will listen to that and go, hello, there's an agenda here. Tell me more about this. You know, it's a flippant way to answer that, but take that hint and take that time now, because 5 minutes now to find out what someone's values are or what the family's frightened of could save you hours, days, or even admission to hospital that no one wanted in the terminal phase. Embrace Google. I'm not sponsored by Google, but it seems to be that we all just use Google now, but embrace it because the family will, and they will come in and they will say, I've read this, I've heard this, what about this? This is changing in funding. What do you know about it? Be open, be curious, you know, use your mindful processes with that and say, great, tell me what you know, because if you don't, if you shut it down, they're going to go away and Google stuff that is probably less than helpful. Have a list of digital resources and links that you can say, yeah, that's awesome. Have you seen this as well? Most people already do this, but don't shut it down, because people still come in and say, oh, I'm sorry, I did Dr. Google and I looked and I said, no, that's good. I'm glad you did, because this is your body, this is your life. You tell me what you found out and let's talk about it together. And then gather your crew. So foster links with formal and informal, or funded and unfunded services. This is good for the patient, for the family, and it is good for you. This is to reduce your burnout and increase outcomes for the families. So it's not rocket surgery, but you know, we're not here to reinvent the wheel either. So what's the GP role in advanced care, end-of-life care planning? And I said before, central, peripheral, or remote. Now, what I mean by that, and we've got here is a little 4-cog diagram that's taken out of the Palliative Care, the New Essentials, beautiful article by Julian Abel in 2018. He's a palliative care physician. Alan Callagher, some of you might know, famous Australian who basically the pioneer and godfather of compassionate communities. And they have sort of looked at how can we do this differently? The way we're set up to do palliative care at the moment, with a real emphasis on specialist palliative care and inpatient palliative care and consultant services, is not sustainable. It can't be sustainable. And we know regionally and rurally, our specialist palliative care services stretch very thin. Even if you're lucky enough to have them, they're stretched very thin. So these are the 4 cogs that make up, ideally, what makes a good palliative care essential service, or essential approach, I should say. And they're combined with generalist palliative care, so GPs, practice nurses, you know, we all sort of sit in here. Specialist palliative care, some GPs sort of fluctuate between the two, but specialist palliative care, we're usually thinking about those services that primarily only do palliative care. There might be consultants, something like that. Compassionate communities is this cog up here, which I'll get back to, which probably needs a bit of explaining for some people. And then there's the civic program. So these are your councils, these are your universities, these are your schools. And if you think about it, you think, oh, what have they got to do with it? They have a lot to do with culture, and they also have a lot to do with, particularly regional and rurally, they're doing a lot of the hands-on work. So your Meals on Wheels, your home help, you know, often they're coming out of shires, they're coming out of civic programs. So if we encourage that level of interaction with the civic program and say, this is what dementia is really about, and this is what end-of-life care planning is about, then people are going to be more receptive to it, because it's something that's already sitting in their lingo. So what are you going to do? Are you going to be, and you probably already know where you sit, you might be central, you might be an advocate for someone with dementia, you might be a coordinator, you might assist them with negotiating my aged care, you might be ready and set up to do terminal care at home or in the hospital or in the aged care facility. Someone's dinging, hope that's okay. And, that might be your bag, as Austin Powers would say, that might be what you like to do. It's what I like to do. I don't do inpatient residential aged care facility work anymore, but I did, and I really enjoyed that. And I liked having people stay there for their terminal phase if that's where they wanted to be. You might be peripheral. You might just see people when they come back and you translate the specialist speak. I don't understand what the geriatrician meant by this when he was talking to Dad. Okay, well, this is probably what he meant. You might explain dementia. You might give them a bit more background about the different types of dementia. And you'll connect people with supports. Some people have more interactions with specialists than others, depending on their type of dementia. So Alzheimer's, we don't see that much specialist input, and terminal care, we barely see any specialist palliative care input. It's basically GPs. You guys are already doing this. But perhaps MND and Parkinson's, certain frontotemporals, and those rare and strange like infantile dementia and stuff, we're very much reliant on specialist input with those. But in the vast majority of mixed dementia, vascular and Alzheimer's, it's general practice. It's sitting here in primary care land, okay? So we've got central, we've got peripheral, and then we've got remote. So maybe this is not your bag, baby. Maybe remote, you're not comfortable with dementia and end-of-life care discussions. Maybe you're not able to do it. It's not part of your, the way your practice is set up, or you're not interested, and that's okay. I'm not interested in skin cancer, but I know what to do if I see something that I don't like the look of. So at the bare minimum, you still need to know how to support your patients. Everyone knows that. So you can't get out of that one. 100% of your patients are going to die. And that doesn't make you a bad doctor. It just makes your patients human. All right. So you need to know where you sit before you start. So you know what you're promising, and the patient and the family know what to expect. So advanced care, end-of-life care planning or advanced care planning, I really dislike the phrase because it's equivalent of saying to someone, if you say to someone, do you have an advanced care plan? It's like you're saying to them, do you have insurance? What sort? House, home, contents, life, funeral? Insurance is a catch-all. So is advanced care planning. Advanced care planning or end-of-life care planning is just a fancy way of saying everything that spans that area from I never want this to happen to me discussions all the way through to wills and funerals and estates, okay? I've put the little star there next to the things that I think as medicos and practice nurses and community people that we're meaning when we say to someone, do you have an advanced care plan? We're usually meaning, do they have an advanced care directive? I can't think of how many times I've said to someone, have you got an advanced care plan? And then bitten my lip and thought that was a silly thing to say. And I said, oh yeah, the thing you go to the GP every year and the practice nurse does your weight and your height, and then you get 5 Medicare subsidised visits to see the podiatrist. No, that's your GP management plan. Oh, you mean the thing where they fill out the paperwork and I can see my psychologist for 6 visits and go back and get another? No, that's your mental health care plan. Well, what's an advanced care plan? Good point. No such bloody thing. What we've got is lots of different things under that umbrella. So I think, generally speaking, when we're asking someone, what's your advanced care plan? We're actually asking them, do you have an advanced care directive? Do you know what you want if you're unable to speak for yourself? And also, have you got a medical treatment decision maker? They're the 2 main things that I think most of us are asking. But when it comes to end-of-life care planning or advanced care planning, it spans a lot more than that. So it can go from having these discussions, someone gets discharged back home after an extended admission and they say, I never want to go back. I never want to go to ICU. Okay, take the hint, explore that. What do they mean by that? Was it because the food was lousy in that particular hospital and they'd like to go somewhere else? Or no, they never want to be ventilated. They know what's coming. They don't want to go back. So find out a little bit more, document it, flag it in your clinical notes as an advanced care discussion or maybe not advanced care directive, but just note that these verbal utterances to a healthcare professional are considered under common law as an advanced care directive. I had a GP I was speaking to recently, one of my lovely colleagues, who's tried to say to an ambulance officer, look, this guy's just hit the aged care facility running and, he's got chest pain, he's going back to the hospital, but he's told me he doesn't want anything and I believe there's his wishes. And she got told, no, it has to be in writing. Okay, maybe ambulance has internal policies, but an utterance, a verbal declaration of someone's wishes from a competent person is under common law considered an advanced care directive. It can be written or it can be verbal. When we're talking statutory, that's when it has to be this is what we're thinking down here with these advanced care directives. They can be values driven or instructional, or both. They don't have to be both, but they can be both. And they are legal if they're witnessed, written in English, and signed, so and dated. So that's a statutory advanced care directive, and that varies from states. States and territories have different levels of that. So what we're talking up here is a common law advanced care directive, but also flag it flag the visit, put it in your notes. So when you go hunting later, gee, Bob said something about not going back to hospital. What was that? And then if you've got time at another visit, bring it up, discuss it. Advanced care planning as such can also include things like, what about that euthanasia thing? Now, this will come up in many different forms, but what it's talking about is voluntary assisted dying. Now, that's not within the scope of really what we're talking about today, but of course you need to know where those resources are. You might be a conscientious objector. I'm a conscientious objector. I still know a lot about the law because I need to know, and it's a legal option for a small percentage of Victorians every year. So here we've got links about common law, advanced care directives, and a VAD overview. Sorry. I apologise, sorry. So what we might want to know is, who would you want to speak for you if you couldn't speak for yourself? Simple sentence. Okay, I want my daughter to speak for me. Okay, well, that's your medical treatment decision maker. Would you like to appoint them? And then there's the form there that you can use to appoint them. The other question you might say is, okay, what would your daughter say about your medical needs? Are there things that you definitely want known? And if there are things they definitely want known and they want to guide their medical treatment decision maker if they're unable to speak for themselves, that's an advanced care directive. Okay, there's a copy of, I've put ACP there, naughty me, it should be ACD, Advanced Care Directive for Adults there. There are different versions, but this one is the Victorian sort of accepted one, and very easy to fill that one out, and it'll fulfill all the statutory requirements for an advanced care directive. Then we get into other things that people sometimes, again, will say, no, I've got a will, that's all I need, that's advanced care planning. Well, it might be all you want, but there are other things if you want to. So do you want someone to help you with decisions about where you're going to live or with your finances? This is particularly important when we've got an early diagnosis of dementia. Some people will want to talk about it, some people won't, and we'll get onto that. You can't force people to do it. But if they want to, this is the time to look at either an enduring power of attorney, which I think is a really good idea, getting that set up. I haven't put it in there, but there's also a supportive attorney in Victoria. Now, supportive attorney is a really great appointment, which, stupid of me, I didn't put it in there, but I'll put it in the resources. And that is someone who can help you gather the information to make an informed decision while you've still got capacity. Medical treatment decision makers, enduring powers of attorney, they don't come into play unless someone is unable to speak for themselves, if they've lost capacity, okay? A supportive attorney is someone who can speak to Telstra on your behalf, who can speak to the banks. They've got the legal ability to do that. They don't make any decisions for you. They gather that information and then they present it to you in a way, or to the person in a way that allows them to then make a decision. But if you want to do enduring power of attorney, there's the link for the forms there. And all three of them used to come out in a beautiful booklet called Take Control. I don't think they print them anymore, and they certainly don't have them with the forms in the back, but you can download the forms, and it's always nice to have a little stack of them in the office. Some people aren't that good on internet, so it's nice to have them there and not have to worry about printing them out. Is there someone who do you want to legally arrange who takes care of your, you name it, after you die? And this includes the body. And this is something to remember too. Your medical treatment decision maker, if they're not your appointed person in your will, your executor, then they have no say over how your body is cared for after you die. It's your executors, your medical treatment decision maker powers stop when someone dies. Okay, so if it's the same person, doesn't matter. If it's someone else, it's worth thinking about. Doesn't always happen, but we used to say where there's a will, there's a family. And sometimes you will see, no pun intended, things that pop up at this stressful time. So if it's the same person, great. If it's not, then just make sure that the person knows that the powers will switch to this other person as soon as you die. There is a little link here on how to do a will, what's involved. And you can get an Australian will kit for $31.50. That's how I did mine. Mine's not complicated though. If you've got lots of estate, you've got children, you've got property, you've got lots of complicated things that have to go into it. All right, this is the one where people probably would do well to pay and go and see a solicitor, get it totally sorted out. They don't need to see anyone, you don't need to pay to see a solicitor to have your medical treatment decision maker done, or your advanced care directive, or your enduring power of attorney if it's straightforward. A will, okay, if it's not straightforward, save money, go and speak to someone who's an expert, because I'm not. And do you want to plan your funeral? This might be challenging to a lot of people. Some people actually really enjoy doing this and actually get quite a kick out of doing it. A funeral plan is not funeral insurance. It's not anything to do with money. There's a link here to a funeral care plan example that you can use just to fill out. And it's really handy, because trying to chase around what your mother's maiden name was, or how many kids and in what order, all things that they need for births, deaths and marriages, trying to do that when someone's died is really hard. If it's all written down, not just, I want flowers and I want to be cremated, that can really help your family at that time of need. So I will keep trucking. So I wanted to point out one of the resources called the Advance Project. Some of you may have heard of it. I hadn't until Emily told me about it. So I thought, I don't know this one. I'm going to go and have a look. So I went and did their training, and they talk about initiating advanced care planning and palliative care in general practice. Now, there's some really great things about it, and there's links if you in the talk, if you click on the icon or any of the hyperlinks that'll come up. The pros of this, the good things about this is there's resources galore. You don't have to design another form to get this information. It's all there. It's very much got a group practice focus. It's designed to have roles for the GP, the practice nurse, reception, everyone involved. So not as relevant for me because I'm my own everything. But if you're in a larger practice, that's how it's set up. And it's got a method of trying to make sure that you've got practice-wide screening to improve that equity, so people aren't slipping through the cracks just because they haven't asked. If they haven't sat there and said, what about advanced care planning? And you've got, oh shit, you might be eligible, it might be good to do an advanced care directive, let's go and look at it. It's sort of screening everyone en masse. There's communication suggestions in there. And I think the training would probably improve confidence in advanced care planning as a whole approach, and palliative care discussions. And what it does is it talks about how to put those discussions into consults to be sustainable and achievable. Now, the cons, and this is just my opinion from doing the training, is that in the video, perhaps the doctor wasn't really taking the hint, that this person saying, I'm on the edge, I don't know what I'm going to do, I'm really frightened. And essentially it was, well, take this form and I'll see you next time. Now, that's not how it's meant to come across, I know, but I don't think anyone would have someone sitting in front of them saying, I'm on the edge, and they'd say, well, I'll see you next week. It's trying to demonstrate, I think, time management in general practice, but it came across to me, just me personally, as not probably the way to do it, because people will ask for help, 2 or 3 times, and then they'll think this avenue is closed and they'll look somewhere else. So if you're chucking those hints out and nothing's coming back, you're going to say, my GP's not interested. They might be interested, they might be very interested, but you're going to look at other directions. So, and it doesn't really allow for that localized strategies and network mapping. But the project itself, lots of resources for a big practice, particularly if you're just starting, how you're going to manage advanced care directives, end-of-life discussions, palliative care in a large practice or a large, or if you're linked with a large aged care facility, perhaps it might be quite useful for you. Steal what you think works for you. I've put a few resources in the folder, but you can also go and do their training very quick. There are also another couple of resources here for you. I'm loving LDAC, end-of-life directions for aged care, and there's some good training in there. I went and did their training too, because I didn't want to tell you guys go and have a look at it if I hadn't had to play with it. There's some good stuff on the law around advanced care planning, good reminders about capacity, and also hierarchy of substitute decision makers. So it's a good resource. You can click on that one as well, and the links are there. And just a shameless plug, not because I want people to hear my terrible voice, but because trying to simplify it, there's 2 YouTube ones that I did right at the start of first ISO, I think, from memory. And one is advanced care directives, and it's, just get it done. Stop talking about it, putting it off. Let's just do it. And I think see one, do one, teach one is the best method for this and advanced care directives in general. So I would say, as Dr. Ira Brock does, I don't have an advanced care directive or plan because I've got a terminal illness. I have it because I've got a family. And I think once we start saying, you know, that we've got to talk about advanced care planning in aged care or in ED, we've missed the boat. This has to come from earlier, and this has to come from community. So I encourage you all to do your own. I've got, this one is about 50 minutes. And then I realised it looked a bit long and involved. So we did Advanced Care Directives Victoria 10 minutes, and it's just done. So have a look at that if you've got a spare 10 minutes to giggle at how terrible I sound and how bad my IT is. All right, so normalise the palliative approach. Again, not rocket science, but use all your interactions as teaching opportunities, both for you and for your patient. I've learned so much from my patients, and I know you guys do too. So someone's just been diagnosed. Maybe, you know, find out where they're at, meet them there. You know, what do you know about dementia? Again, this is simple stuff that we all sort of know with communication, but it's not about handing them a pamphlet when they're diagnosed. It's where are they up to? If they say, my mum had it, my grandma had it, I've seen what happens, I know that's the way it's going, I want to get some stuff organised. Well, you've just saved yourself, you know, 3 weeks of work, and you can just get the paperwork done, but also they don't have to focus on that either. What they can do is focus on enjoying life. So I think of it like the pre-contemplation, contemplation sort of strategy for change with smoking. You know, where are people at if they're not even thinking about dementia as being important to them, or that it's a terminal illness? You sitting there and banging on about it is not going to help them. So you lean in, you approach it, you ask, okay, they're not quite there yet, you step back a little bit. This is in general practice, okay? And this is all your interactions. So someone comes in and says their best friend's mum was just diagnosed. Okay, what was she diagnosed with? Oh, dementia. Oh, did you know there's different types of dementia? Again, I feel like I'm teaching you guys to suck eggs. This is like basic stuff, isn't it? But use that, and use that opportunity when people say, oh, well, they made her palliative. No, what they did was they recognised that someone was in their terminal phase with an illness. Nobody made her palliative. They didn't walk up the stair and go and made her palliative. This is the way we've got to look at the language. And each opportunity, you're actually improving that person's health literacy, or more central to my thoughts, their death literacy, their understanding of what palliative care is, what terminal phase is. They increased the morphine. They put that syringe driver on and she died. Okay, yes, it might take an extra 2 minutes out of your consult, but to try and correct that misnomer rather than brushing over it will save you hours and days at a later time. You can build it up over time. That's the beauty of general practice. I'm not talking about when someone's been admitted with severe dementia into an aged care facility. We'll get to that. But we have different presentations. We have different symptom patterns. We don't have enough time today to talk about all the different types of dementia. There's lots of education out there on it. But being aware that there are different presentations and there are different symptom patterns is vital. You guys know that. Your patients may not. Sometimes people just think dementia is the diagnosis rather than it being insurance. It's the catch-all. There's lots of parts that can go into that. And number one thing, even though I've put it third there, is not every patient will want to engage in this discussion. And not every doctor will want to engage in this discussion. So put energy where energy is needed and where it's wanted. If someone shuts you right down, my dad's a GP, was a GP for 43 years. He will not do an advanced care directive at all. He just flat out refuses. And that's okay. That's his right. He's got a medical treatment decision maker, and that person will probably have to make some decisions, but he will not do it. And that's okay. That's all right. So it's not for everyone, but if you don't ask, you don't know. All right, very busy slide. Again, I've gone for resources over prettiness. And just a reminder that Dementia Support Australia is brilliant, and there's lots of resources out there. I did see Emily did a lovely thing at the start of the talk as well with some links to DPMAS. If you haven't had anything to do with Dementia Behaviour Management Advisory Service, lucky for you, that's good, because it means that your patients haven't needed it, but they are wonderful, and don't have families suffering alone. Really try and see if you can engage them with Dementia Support Australia, and they are wonderful. There are lots of ways to help. So early dementia care practice tips is to normalise dementia treatment in a palliative care framework from diagnosis. So talking early, talking about values, what's important to you, what's important to mum. You know, not would she want antibiotics if she has a chest infection, if. You can't cover all those things. What you can find out is what is important to that person when they can still tell you. And then when the time comes that something's happened and they can't tell you anymore, you've got their values, you match it with your goals of care, you know, you match it with the treatments that are available. You don't just offer them everything on the list. You say, right, well, you want to stay at home, you want the cats on the bed, you know, you want your family around you. Me admitting you to hospital for antibiotics for urinary tract infection, which hasn't actually been shown to reduce morbidity or mortality in advanced dementia, is against your values. So we won't do that. We'll do something else. But if you don't ask, you don't know. So 10% of Australians over 75 will have a dementia diagnosis. We need to have more understanding in the community what it's about, and we need more community support. About 70% of people with dementia live in the community, and so they're most often the mild or moderate. They might be the ones that have really, really, really great social supports, but they might also be in the early stages or have less challenging behaviours. Interestingly enough, over 50% of aged care residents will have a diagnosis of dementia somewhere in their file. So I try, and this is again just my opinion, but I try and focus very much when I'm talking to someone early on. If you start talking about advanced care directives or what do they want in the future, oh, I don't want to talk about dying. Well, it's not, you know, 2% of doing this plan is about dying. 98% is about living a better life. This is how you want to live your life. It's not about dying. It's actually about what makes life good for you. Say that, very few people say, I don't want to talk about it. You'll get some, but you won't get many. If you need symptom control help, you've got your DBMAS and your SBRT, Severe Behaviour Response Team. Haven't had anything to do with them, but I'm sure they're excellent as well. And I've put some links here as well for engagement tips. One of the questions I got before we started this talk was on how to engage people with dementia. How was it worded? Creative suggestions of engaging a person with dementia, please. I love that question because it's not about how do I keep this person busy. It's not about activity and taking up time and killing time, if you like. It's how do I engage them? So what interested them? You're not going to send someone who's lived their life in an office, you know, management and doing work with papers and computers. You're not going to send them outside to pull weeds if that wasn't what they were good at doing and what they liked doing. So what did they want initially? And then there's different ways of engaging through that. Because we'll be running short of time, I've got some tips there and I'm happy to talk to people afterwards as well. Really important to keep at the front of your mind that a diagnosis of dementia doesn't mean that someone doesn't have capacity. I've put a resource of a capacity letter template in the folder that just basically put in as any of your other template letters and bring that one up and it'll come up with Mr. blah, 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 and put all their autofill their details. But basically that if you've assessed someone and they can, if you give them time, you give them the information, even if you have to repeat that information every 2 minutes because they can't remember it. But if you give them that information again and again, and they're able to absorb that and tell you what they think about that and make a decision based on that, a consistent decision, they have capacity to make that decision. So I really struggle when people say someone's got no capacity. They might have no capacity to, you know, I don't know, be a president or a prime minister or something. Well, maybe they do, but it's not a blanket thing. It's not an all or nothing. It's situational dependent or task dependent. Do they have the capacity to decide between the blue dress and the red dress? Yeah, they do. Do they have the capacity to decide whether they go to hospital for antibiotics? Don't know. Let's ask them. What do they want? What have they said in the past? That being said, as dementia progresses, sometimes, and as dementia progresses, we will have a lack of ability to then complete an advanced care directive. Now, having a statutory directive or even a common law advanced care directive requires the person to have capacity to make medical decisions. So you've given them the information, they've thought about it, they've thought about the repercussions of that. If I don't have this treatment, I might die more quickly, but I'll be dying at home. Yeah, I'm okay with that. All right, that's a common law type level. Statutory, they fill out the advanced care directive. If they can't do that, if we've missed the boat, there are still ways to support their values and to be involved in that process. There's a really great reference and resource called What I Understand to Be This Person's Preference and Values form. A little clunky, a little long in the name, bloody good form. This can be filled out by aged care workers, you know, your personal care attendants, the people who see this person every day, as well as their family. Do they like showers? No, they hate showers. Okay, well, you're not going to suggest that they have a spa day as a way of engaging them. You're going to think of something else. But it can also put in there, you know, what frightens them? What do they really enjoy? What music do they like? Simple stuff, but it's there on the form. And that, again, is something that would guide me as a GP going into an aged care facility or going into a home. If someone can't speak for themselves, they didn't have the capacity then to complete an advanced care directive, but I still know more about their preferences and values, and I can use that to guide my treatments. All right, very busy slide, and I apologise. Try and keep the eye on time. Advanced dementia care practice tips. So this is my sort of cheat sheet. It's a terrible abbreviation of READCAD. Feel free to anagram and rearrange that into something more pleasant. But these are the things that I try and think about when I'm preparing for terminal phase care, whether it's at home, in the hospital, or the aged care facility. And some of these things will have more emphasis than others. You know, you really got to think about how someone's going to get the medication if they're in rural and regional Australia and at home. If they're in the aged care facility, you might still need to think about it, because depending on the size, you might not have an imprest. There's no point ordering fentanyl for someone if the local pharmacy doesn't have it, you don't have an imprest, and you know, it's not going to get here till Tuesday. Let's be practical. So think about this beforehand. There are lots of resources, and as Emily put up before, Health Pathways has some excellent ones. I've just put the Western Victoria link there because that's the only one I have access to. One of the other questions that I received earlier was, how do you best assess pain in dementia or non-verbal patients in the palliative care setting? I've put some pain assessment tools here, but basically I'd be having a look at them sitting. If they're non-verbal, looking at their appearance, are they grimacing, are they tight? You can see usually when someone's in pain. You might not know the level of it, but you know that there's some discomfort there. And honestly, I try analgesia. You know, you try it, give it a go. Worst case scenario, you might get them a bit constipated. You're aware of that. If you treat it and they're feeling better and their behaviour changes, great. So the pain assessment tools to answer that question are there. Palliative Decision Assist Toolkit, I have that on my phone. I don't really use it as much anymore, but it's a handy app, particularly if you're sort of thinking, what have I forgotten? There must be a gap here. Going back to my terrible READCAD, basically, I think about trying to rationalise medications, observations, dressing and diet, and share it with the carers. There's no point just stopping someone's blood pressure and telling them to eat whatever they like and stopping their insulin if you haven't explained it to the carers. This person's been on warfarin for a long time and you're just going to stop it. They're going to think that's going to kill them. You need to talk to them about, okay, well, the warfarin did its work really well for many years, and that's how mum, dad, brother, whoever it is, could get to this stage. But now it's actually more dangerous and more risky because she's falling over, you know, we've got unstable INRs, whatever, and explain it. And then stop it. Very much a bugbear for me is seeing lots of statins and blood pressure control medication still on charts. Yes, there are internal policies on measuring blood pressures and weights on in aged care facilities, but I think if you discuss it, you discuss it with the family and you say, this is where we're at, and we're not going to, you know, keep them on a diabetic diet for the rest of their life when they're not actually eating anyway. Rationalise it, talk about it with the family, but simplify things for them. Educate on symptom control, administration, and get equipment and consumables. Number of times when I first started doing community palliative care that I'd get out to the house and then think, oh, didn't bring any pads, didn't bring any blueies, didn't bring any Kylies, didn't bring any mouth care. So now I do carry all that stuff with me. And I have people actually film me putting in a butterfly if that's what they need in that advanced situation so that they can get their subcut medications. If they film me on their phone, they've got it there. It's a bit of a backup. Always give them written information as well, but it's handy sometimes to see a video. So we do that because if you actually prescribe the medications for subcut symptom control and leave them with them in the house and with a butterfly and have it all there, but then don't teach them how to administer, you've basically given them a brand new car filled up with petrol and then taken away their keys. They can't do anything to help their loved one if you haven't actually allowed that next step to happen. Anticipatory prescribing follows on from there from symptom control. Let's think about it. So not just prescribing, but dispensing and delivery, like I touched on before. Really important and something I didn't always think about. And yes, if someone's on 800 milligrams, that's a bit ridiculous, but it happens, 800 milligrams of morphine a driver, you know, and you only write them a script for 10 amps, it's not going to get them anywhere near through the weekend. So sit down with your calculator and just say, I just need to check I've got enough for you, work it out, do an authority script for that much. Log on to Proda, get it done, okay? Or however you like to do your authority scripts, but make sure they've got enough. Check with the pharmacy. If it's a big order, it's a Friday afternoon, it's a big order, check with the pharmacy, make sure they've got enough. You don't want an admission to hospital from aged care or from home if there aren't actually supplies of medications that you knew this person would need. So just thinking a little bit ahead. Document and share a plan for symptom control and a backup plan. I'm talking, again, overlap of home and aged care facilities. Mostly home in this one when I'm talking about ambulance. Some people worry that if their loved one falls, that they won't be able to get them up. I don't want to use the ambulance service as a purely how to get people back into bed job, but they can treat and refer. Rural Ambulance Victoria, RAV, a fantastic crews, wonderful. They don't want to transport people who don't want to be transported, but people need to know that that's what's happening. And having some guidance there, having a letter there for the ambulance, always handy as well. Document and share the plan for symptom control. If dad has pain, he can have this medication, if this, and spacing it out, and who to call with the after hours stuff. If they're in the aged care facility, same thing, write it down. First option for pain control, or first option for anxiety, second option, lay it out, nice and clear. I like it to be what we call 3 o'clock in the morning test. If I'm blurry-eyed and I get called at 3 o'clock in the morning, I need things very, very simple. Try and make it as simple as possible. If it never gets used, if they don't have any symptoms at end of life, great. If they do, then you've got a plan to manage it. Communicating the prognosis to everyone. Of course, this is with consent, of course, but tell people, you know, if this is happening, if we're talking that this person is in their terminal phase, talk about it. Okay, this is probably going to happen. I'm happy to be called, or I doubt, you know, you'd say don't call me, but, you know, if this is going to happen overnight, if it's expected, your local facility might have a situation where they say, right, we'll call you in the morning. If everything's going fine, fine. Clergy, you know, a number of times I've forgotten to inform some spiritual advisors that something had changed. They're part of the team. Talk to the pharmacy, tell everyone. Funeral director, I've gotten much better at that. I never used to think about that because, I don't know, I sort of seem to leave them out of the loop. But if someone's told me they want a particular funeral director and it's going to happen overnight, or it's going to happen really soon, funeral directors love a heads up, you know, and then the family don't have to think about, what does dad weigh? Are there any infectious risks? You know, how are they going to access it? If you've already warned the funeral director of all those things, then they don't have to hit the family up for that information, and the family don't have to remember it to give it to the funeral director. That's something I've learned recently. Arrange an ambulance letter and clarify an after hours plan. So who do I call when? I like to just have one number that they call. Sometimes you'll have two. You might have yourself and you might have a nursing service, or you might have someone in the aged care facility that might be very clear, but clarify that after hours plan. Tell them, write it down. Document and share the bereavement plan. Okay, again, the nurses will come, or I will come, I will call, tell them what will happen next. People have gone from being a full-time carer, particularly with dementia, even if the person was in aged care facility, that's part of their identity, as well as their role, as well as their, you know, love. And they've gone from that to suddenly nothing. And sometimes they can feel extremely abandoned. We think people feel abandoned when their specialist says, you don't need to come in anymore. Think about when suddenly the person's not actually there anymore, not a patient anymore. You need them to know that you're still there for them. Did that come out right? They need to know that you are still there for them. And but be clear, you know, if you're not available, find out who would be available and contact them, or say, I will come and see you next week, and write it down for them. Again, we don't have a lot of time to go into specific symptom control stuff depending on disease state. I've just broken it down there very simply into the areas that you would all know. Alzheimer's disease, vascular, of course, can have mixed. Lewy body dementia, think about that. Think about medication differences that you would use differently. And then we've got frontotemporal. So we're thinking Parkinson's, we're thinking motor neurone disease. I didn't really clock it until recently with my cousin who had MND that, you know, everyone with MND is somewhere on that spectrum of having a frontotemporal dementia. Some are quite advanced and quite obvious, and some are very mild, but I hadn't actually thought about it like that. And so you've got two illnesses really killing them. And not addressing the dementia side of it, I think sometimes limits people's quality of life. I've put in symptom control, I've put spiritual needs first because I feel like every palliative care talk I've been to, or advanced care planning talk, we talk about pain first. Sometimes if we get time, we talk about anxiety. We might talk about breathlessness. We maybe talk about confusion and then spirituality, and it just trails off and nobody talks about it. So I've put it first there just to remind ourselves that managing people's spiritual needs, or the fancy term that we use of existential distress, managing that early and people's expectations actually does wonders for symptom control. If someone's terrified of drowning and you haven't thought about that and addressed it with them, even if it's as simple as saying, you're dying from dementia, you're not going to feel like you're drowning. Simple statement. But if you say that, oh, good, because they don't know, or they've seen someone, they might have seen someone with heart failure, and they might have seen or heard the rattle. If you don't ask what their fears are, then you can't address them. Spiritual needs are more than just religious needs, although both are very important. So I've put that first. And of course, it's not all about the medication. I'm very much at fault when I'm doing talks of only talking about morph, midazolam, hyoscine, haloperidol, metoclopramide. That's about it, until we get into the fancies. But there's lots more to that that people can do, and helping people transition from food being love. You go and see someone in the hospital, even if they've got diabetes, you're taking them a box of chocolates. It's crazy, but it's what we do because food is love. So helping a family transition when food is love from feeding to maybe hand massage, or give them a shampoo cap and they can wash their hair, different ways of doing it. Care for the carer, looking out for them. How are you doing? How are you coping? Do you need some help? Do you need some support? Mouth care. I'd never actually taught anyone how to do mouth care. I just kept handing them the swabs and the stuff. And then when my cousin was dying, I thought, this is really hard to spray in her mouth. And so I learned some different tricks. You tip a little bit on the spoon, this sort of thing, and different ways to use the swabs. Just saying, those jumbo swabs go really well dipped in anything. I will have red wine or I will have caffeine. Thank you. All right, so music, so much better for soothing people. We've worked with some amazing music therapists, and you can see the correlation between the increase in music with a decrease in midazolam. Swear to God, it's what happens. So think about it and see how you can use that. Fans, so good for air hunger. Just think about those things as well, not just medications. A couple of links to some good resources there. Dementia Australia, wonderful, wonderful resources. Palliative Care and Advanced Dementia paper from 2020 is actually really, really good, quite detailed. There's a link there. And of course, for the RACGP, we have the silver book. I think it's silver for the lovely hair, but it has obviously a large segment on dementia. So how we go for time? Not too bad. So billing strategies and MBS item numbers. Sorry, no magic bullet. We're not likely to get better rebates, are we? And we're not likely to get new numbers anytime soon. And one of the reasons for that is because the Medicare benefit schedule is national. All our advanced care planning and advanced care directives are state and territory. So we're not going to get a national number for advanced care planning. It just won't happen. I don't think. I'd love to be proven wrong. So we need to have a think about, what are we going to do? Let's work smarter, not harder. So I've put up here some item numbers 160 to 164 that I didn't even know existed until a couple of years ago. So I certainly didn't use them. And these are the ones that were referred to in that article that I showed at the start. They were saying the college wanted better guidance to GPs to make sure that they knew that these numbers were available for palliative care. My ears pricked up and I thought, new numbers for palliative care, how exciting. I had a look. It's not. What they're doing is doing what we do all the time, is using palliative in place of terminal. It's like when we say they're palliative, we whisper because, the cancer might hear us. It's crazy. We're using the words wrong. How are we going to expect the community to use them in a way that's working? So what they actually mean is the numbers of 160 to 164 are for terminal care. All right. So anytime, any day of the week, any site, imminent danger of death. Okay, so one or more practitioner can claim with simultaneous attendance and doesn't have to be continuous. So I have used these numbers quite a bit now because I might go out and see someone. It's been a big change. They're clearly entering their terminal phase. We've had a chat. Okay, we're going to start subcut. We're going to stay at home. Or in this situation with dementia, they're going to stay in the aged care facility, for example. All right, you've done that. You go back to your clinic. You're doing your stuff. You get a call, you got to go back, you got to see something, you got to change something. All right, these are adding up. In a 24-hour period, you might go back 3 or 4 times. You can use these item numbers. That's what they're there for. Imminent danger of death. I did get a bit of guidance on this one by someone who works closely with the Naughty Review Board. And he said, no promises that this is exactly, but this is how I would interpret this. And it's imminent danger of death. So if I had a very long consult with someone and talked about their advanced care planning and all their issues because they've just been diagnosed with non-small cell lung cancer or something, or even someone who's just been diagnosed with dementia, if I sat there and they were really distressed and I talked to them for 3 hours, I still couldn't bill one of these numbers. okay, because they're not imminently dying. So we won't misuse this, but in terminal phase, terminal care, that's what they're there for. And I encourage you to use them, because if we don't use these numbers, then if they're not getting used, MBS doesn't know that this is needed. Use the item numbers. They are being used. This is a need. Oh gosh, we are doing more palliative care in general practice. Surprise, surprise. Okay, well, maybe we need to put some more funding in there. We can dream, can't we? All right, so one of the other questions was costs and recording of after hours and electric records. There is an MBS item number using the palliative approach cheat sheet in the folder. And it is, it sort of lays out which number you use where in the after hours period, whether you're at home, in the aged care facility or in the hospital. I use a remote desktop to access the notes, and that's what I did when I was in a larger group practice as well for when I'm at the aged care facility. Nothing worse than writing your notes and then having to go home and then have to either write them again or write them the next day retrospectively. Write them at the time. You know, you're not getting paid extra for doing the notes. If you write them at the time, great. One time when I couldn't get stuff working, I just took a photo of my notes, de-identified, blah, 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 all very confidential. I'll probably get in trouble now for saying this, but I took a photo and I imported that as a document because they were bloody good notes and I wasn't going to spend an hour writing them again. Autofill, there is some links and resources in the folder. One is I've got the resources of the capacity letter. The other autofills I've got in there are a palliative care checklist, you know, going through and a bit of an aid memoir. So you do your autofill, if people know what that is. So you have your own little shortcut. I have discussed with patient about advanced care planning. That many letters, and it brings up a whole scree of what I normally say to people anyway. So it's exactly what I'm doing, but I don't have to tell them that and then spend 20 minutes writing it down. Practical things, okay? I also save resources like the Advanced Care Directive, the Medical Treatment Decision Maker, the Enduring Power of Attorney, all that stuff into the patient education leaflets and set up my, my preferences so that it shows in their file when I've printed it. So it'll come under actions, you know, you've printed this script, you've printed this script, you printed out the Advanced Care Directive. So that will be, you know, you open up their file next time, you have a look, oh, I gave that to them 2 weeks ago, I wonder how that's going. And it helps you remember it and you haven't had to do a thing except print it out. Cheat sheet, there's lots of different resources. Thank you to the PHNs who have got some amazing resources of all different types on billing. None of it's rocket science. You just have to make sure you're billing the right numbers. Unfortunately, there's no magic answers here. But particularly in a large practice, you're going to have better ways of structuring it, perhaps even using that practice-wide approach from the Advanced project of how to work this sort of advanced care directive discussion into your consults. So improve outcomes, this is where I start banging on more about my personal passion, which is compassionate communities, because I've been thinking about it. Why do we expect GPs to try and do the work of everyone else? We don't expect, you know, your specialist palliative care physician to organise transport for someone, but we seem to expect it from our GPs and our practice nurses. So let's try and share the load a little bit. Who have we got around us to help improve our outcomes? We can improve these outcomes for patients, family, communities, and ourselves, our GPs, our practice nurses, and our community workers by a couple of very simple things. So number one, assessing your own death competency over time. So this is the coping with death scale, and I believe Emily's going to share a link with that very shortly, which is part of the survey, which is sort of a point in time measure of where you're at. Not quite a mini mental state exam, but very similar. Where are you up to? You know, how are you feeling about this? How are you coping with it? Because if you're coping better with these discussions, your ability to cope with someone else in their distress is improved. If you're burning out, you really can't help anyone else. Apply your own oxygen before helping others. So have a look at that. The other thing I really like, but it's more of a community base, is using the Death Literacy Index. Wonderful tool, which you can find out what your area is like now. You know, what do they know about home deaths? What do they know about advanced care directives or advanced care planning? What do they know about dementia? I don't know. There's lots of different parts to death literacy. Look at it now, do some education, look at it later and see where the gaps are. Build on what's strong in that area and then see what you can do to address those gaps. Fostering your links with local supports, both formal and informal, paid and unpaid. So we do, there's a fancy term for it, wank word, is network mapping, okay, in your area. So who does what? Who's who in the zoo? Who does this and how do I connect with them? So I think really what GPs probably want to know most is, who's the specialist palliative care people in my area? How do I refer to them? Are they consult only, or are they going to see this person ongoing? Are they going to do the Ritalin scripts? Are they going to source the, I don't know, anything? Or are they just consulting? And what hours do they operate? We've got different specialist palliative care nursing services around the state and around the country. Some of them are 24 hours, very few of them now. We're very blessed that we do have those. So keeping that in mind. Or do they outsource to your local nursing service over the weekend? You've got to know who does what. So that's the one I think you're probably all most interested in. So you can switch off now. These are the other things. Who else in the area is already doing advanced care planning? Who is doing this stuff? Who is teaching people about funeral plans? You know, is there someone who's already doing this work? Who's doing the navigation and the connection? Some towns it's the, well, in a town very close to here, it was the postmistress, and she and her husband do amazing things. They're not working in that role anymore, but they still do the navigation and connection, and they know what's going on. Something happens in that town, I call them. Or is it your hairdresser? Is it your taxi driver? These are all people who know who does stuff and connect people, and they're signposting. They don't have to do all the work, but they can say, hey, did you know about Anam Cara? Did you know about some other group? Do you know if these people are around, and can you connect with them? Who can do the legal support locally? I stupidly thought that all solicitors did wills and estate planning. Not necessarily. So good thing to find out early. Who does this work? Specialist palliative care we touched on. Who does the direct care? Who does personal care in your area? Is it your council, and how do you refer to them? Do you know someone? Is there someone who you could be on first name basis, so that if you had a situation with someone with advanced dementia who went from doing okay to suddenly they got pneumonia, family wants to keep them at home, they're going to need help washing in the bed, nursing service can't step in, or can but can't do as much. How do I connect with the people who have the personal care attendants? Who does the showering in your community? Who does the cleaning? Who does those things? And who provides respite? Respite is massive. I've had 4 calls today for people needing respite. And it ranges from people who have extremely high needs and terminal phase needs, but they're not always the same thing. Sometimes terminal phase, there are less things to do, and it's more just about being compassionate presence, all the way through to someone who just wants compassionate presence, someone to sit with mum for 3 hours while I go and do some shopping. Who does that locally? Who does the care of the carer, you know? Who would you call if you needed someone to have a short transport somewhere around town? Is there a community car? Does the taxi driver happily do some sort of little odd jobs for you? Who does meals? Who's happy to go and cook up a whole heap of meals if you don't have a Meals on Wheels service in your area? Who does the respite? Again, this is a big thing. Who does the listening? Who does the compassionate presence? Who wants to sit there and hear the stories over and over and over? I've got some amazing, beautiful volunteers who have put in around 15 hours a week with a family who had a husband and wife couple who wanted to stay at home, husband with advanced Parkinson's but no dementia, and wife with advanced Alzheimer's. He has since died. They are still going and sitting with his wife. And I think we're down from 15 hours, but we're still providing a lot of community support for that family. And the family is so grateful. And these people who volunteer love it. And they love hearing the story 6 or 7 times. They're okay with that. And being able to sit with that person has been amazing benefit to the family, to the person, and also to me as the GP, knowing that the family is supported. Who does the care of the body? You know, who's doing that after death care? Who's doing the funeral planning? Amazing amount of people, when someone dies at home, still think they need to call the police, you know, the ambulance or the police or both. So really lay that out for people and find out, is there someone who does this work? Is there someone who will sit with the family? Is there someone who will help them care for the body? We just got recent investment of a cooling blanket as part of a project with Grampians Regional, I'm going to get it wrong, I'm sorry, Grampians Palliative Care Consortium. And that will enable people regionally and rurally to have their loved one at home for longer, if that's what they want to do for a home-based vigil. Grief support. Doesn't have to be psychologists. Okay, who does the grief support? Who knows how to sit with someone and not try and fix them? Do you know who these people are? If you've got that information tucked away somewhere or written down somewhere, or just, you know, knowing you can find them, then when it comes crunch time for a family, you don't have to run around crazy or say, I can't help you. You'll have those resources there. And that's when we go from having this GP sort of cog here trying to do all the work of the compassionate communities, half the work of the civic program, and trying to manage the medications and know when to rationalise. We have primary care trying to do all 4 cogs of palliative care sometimes, and that will burn you out. Trust me, I know. So what's a compassionate community? I'll do this really quickly. I'm sorry, I think we're close to time because I've said it several times now, so I better tell you. Where people are encouraged to engage and be informed about death, dying and care, and adapt their behaviour to be active in supporting others at the end of life. So they don't have to be doing all the care, they just have to know a little bit about it, and they have to know where to go to get that support and that help. So what do compassionate community organisations do? They run training programs in the skills needed to look after people at the end of life. They can be very practical skills. They can be simple things, you know, sitting with someone, trying not to fix them in their grief, for example. Compassionate communities advocate for community-led advanced care planning within the networks, and that's something that I feel very strongly about. Develop a directory of resources that support end-of-life care in the community. Oh, hello, this sounds like what the RACGP was saying we needed to pay someone to do. Our compassionate community organisations are already doing this. They know what the local strengths are. Use their knowledge, okay? Community members have experience, energy and time. Use them. I can't think of the number of retired doctors, nurses, palliative care, specialist nursing, PCAs, farmers, dog groomers, bookbinders. We've got an amazing amount of people with amazing amount of different skills, musicians who have just said, we're here to help. You know, palliative care made a huge difference when my wife, dad, whoever died. I want to give something back. If we shut out the community, we're saying we can't cope and we can't do all this, but you guys can't do it either because you're not specialists, you're not formal. What rubbish. You know, we're all part of a community. If I had a neighbour who needed something, they needed a 4-wheel walker and I had one, I'd lend it to them. I might say to them, look, it's a bit dinged up, but you know, if you want to use it, if they've got the capacity to make the decision to use it without getting an OT assessment, a ramp and a 5-point plan, great, they can have it for free. So this is about getting the community back into doing a lot of this stuff. And that saves our GPs, our practice nurses, and our specialist palliative care services for doing the higher level stuff that's not meant to be hierarchical, for doing different stuff, symptom control perhaps, or coordination. I don't want to have to spend my time running around as a GP organising someone to get frozen lasagnas if there's someone in my community who really wants to do it. All I need is consent from the person, and then consent from confidentiality agreement from the person who's involved. You know, you don't talk about this, but this is what you do. Fine, done. And guess what? I haven't had to do a thing. The community feels better and feels engaged. The person's supported, and I can breathe at night and don't have to do notes until 3 o'clock in the morning. It's good stuff. So train our community members to support end-of-life care, connect people with the supports they need most. Overseas, a lot of this is called what we call community connectors, and there's some really beautiful programs overseas that are working a lot more strongly than ours here. So if you want to know more about it, feel free to send me a message, because obviously this is a bit I'm passionate about. And we see so much dementia, and we're going to see more of it, and trying to keep people at home in our communities is going to be even more important in the future, and keeping people out of hospital if that's where they don't want to be. Keep saying that backwards. If they want to be at home, let's help them to do that. So our community programs encourage social cohesion, formation of communities bound by compassion. Their members look out for and support each other. Oh, hallelujah. So not everyone who's grieving needs a psychologist. Sometimes they just need someone to have a cuppa and a chat. Little tiny plug at the end for people who are doing that homework or facility work. If you don't have an imprest, Shannon's packs are something that Shannon's Bridge, the charity that I helped co-found, we made these up out of donations, and we make them to give out to GPs or bush country hospitals, whoever's doing the 3 o'clock in the morning call out. And they're an emergency symptom control pack for common palliative care issues at home. So we give them out free to the primary care provider. They're completed by that provider by adding the appropriate medication for the patient. So there's a little AMP box in there. It's a really bad picture, sorry, but there's a link up here with a little bit more information about what's in them. Now, these are not to replace good discharge planning. They're not a get out of jail free card and someone walks out, hand them a Shannon's pack. this needs to go with education, with support, with a 24-hour contact detail to each family. But it's got something in there for the bowels. It's got something in there for mouth care. It's got tape for labelling the syringes. It's got syringes to draw up medications. It's got blunt drawing up needles. It's got an amp opener. It's got 2 butterflies. Butterflies are about $6 or $8 each. I don't have, well, I never used to have any in my doctor's bag. I've redesigned it now and I have lots. But when you can put a butterfly in and give someone relief and then allow the family to give subcut and teach them to do that, you've given them the keys to the car. You've helped them to take a bit of control over an uncontrolled situation. This supports the excellent work of our specialist palliative care services. It is not to replace them. It goes hand in hand. If they don't need it, great. And often it's really just to bridge that gap. So I'm talking 3 o'clock in the afternoon on a Saturday and we can't get extra support until Monday. All right, how can we bridge that gap? Here are some things. It's a band-aid, okay? It's not perfect, but it can help. Email shannonsbridge@gmail.com if you want to pack and I'll send them out. Last thoughts and then I'll shut up, and Emily's probably chafing at the bit there. Please, if you don't do anything else, can you banish these from your repertoire? She has been made palliative. No, we've just recognised that she's entering her terminal phase. An advanced care plan. Yes, and I have insurance as well. Ask what you want to ask. Do you have an advanced care directive? Do you have a medical treatment decision maker? Too sick to go home. Oh, I thought this had gone away, but I've heard it recently several times. What you're really probably meaning with all the love in your heart, or what the person who said it really means is, we're worried about how you're going to manage at home. So what can we do to help you? But nobody's too sick to go home. They can be dying, but nobody's too sick to go home. All right, so I will stop here for questions. There's my email. And if you want ComCom resources, they're there for Shannon's Bridge, and there's the link to the drive there. I'm sorry, Emily, I talk way too much.
No, Claire, you're actually bang on time. You've done an excellent job. Thank you so much for that really just wonderful presentation. And there's been lots of praise sort of in the chat too, just to thank you and say what a wonderful presentation that's been. This brings us to Q&A time, where we can answer some of the questions. Thank you, Claire, for answering some of those questions in advance that we received and sort of weaving those into the presentation. So that was wonderful. Thank you. There have been a few other questions provided through the Q&A channel. One of them is there a level or score of dementia at which the advanced care directive is no longer possible? Do you have any guidance around that?
It's a very good question. I think a geriatrician would probably have a very different answer to mine. I wouldn't say that, obviously there's mini mental state exam scores that will qualify you for medications, say in Alzheimer's disease. What I would say is, can you give someone the information? Can they process that? Can they tell you what that would mean, what that outcome would mean? And can they retain it for long enough to make a decision? That would say to me that they've got capacity to make their values known at the very least. There are sometimes questions that come back after someone's died, if someone's got dementia written in their death certificate, depending on when they've done their will, etc. I don't have a firm feeling for an actual score or a cutoff. I think capacity is more, sorry to use the buzzword, nuanced than that. It's more about, can they retain that information if it's given to them in an appropriate way to make their values known? Because an advanced care directive values is so valuable, so important, that I think there would be really good room to, even if you couldn't feel comfortable to sign an advanced care directive, you could make a common law advanced care directive rather than a statutory. I hope that helps.
Thank you, Claire. Another question is around where there is impaired communication, so whether that be around sort of language or hearing or even blindness. Do you have any insights to share when some of those elements are present in that sort of end of life care stage, and just any strategies or important considerations?
So you don't mean in terms of capacity, because obviously just because you can't tell someone, say the words for your wishes, if you can communicate them in another form, it's still valid. You mean in terminal phase? Is that the question?
The question hasn't been posed specifically, so whichever kind of angle you would like to take on that is fine. I think just where there are those elements, what do you need to consider when you're supporting that person or that family?
Absolutely. Think about it early. You know, if you can see this coming, that you've got someone who has a language barrier, you've got issues communicating with them, think about it early. There is a phone line for translators, for example. Have you got someone who can sign? You know, how can we actually work on that so that you feel comfortable that the information is going to that person and coming back? I see the question here, thank you. And also IQ challenged. Who is the de facto carer / decision maker? I've probably got a better answer for this. The barriers one is in terms of cultural or language. I think about it early. When it comes to terminal phase, we kind of miss the boat. It's like doing an advanced care directive. When you get to aged care, you've got to think about it early. Try and find the ways of communicating to bridge those communicating gaps early. It's hard. I'm not dismissing that. It's very hard. And that's when you need to gather in your resources. But in terms of who's the de facto carer / decision maker, there's a very clear substitute decision maker hierarchy in Victoria. And it goes, it's on the website, it's Office of Public Advocate, and there's also an app, you know, can my adult patient consent, and you can work through that. But basically, it goes medical treatment decision maker if someone's been appointed. If they haven't been appointed, it's if someone's been appointed through VCAT, that's the next person. Under that comes de facto marriage life partner. You know, the person who is their partner in life is the next on the list. Under that, I believe it goes children, and then it goes siblings, and then it goes parents. And that's really tough. I've got a young person at the moment who the mum thinks that she's the substitute decision maker, and she's not. The boyfriend who she's been living with for 4 years is. There's no conflict at the moment, but it is tricky. So if someone has an intellectual disability, they may already have someone appointed by VCAT. So you would look at that, or you'd look at the hierarchy if you weren't sure. If there's no conflict, it's not an issue. If you're ever not sure, Office of the Public Advocate give excellent advice, and they're very good for guiding you, because you just want to do the right thing for your patient and for the family, and they want the right thing too. So I would give them a call if you're feeling stuck.
Excellent. Thank you, Claire. Another question is, does music reduce the use of midazolam for just pain or also nausea too?
Great question. I have seen it for anxiety. I've seen it for nausea. I've seen it for appetite. It's amazing. I wish I had the time and energy to do a presentation. Wonderful music therapist who used to work at Peter Mac and used to work in the transplant ward where Shannon McKnight, who the charity I work for, volunteer for, is named for, used to get some amazing results just with music, and it is exceptionally strong. I haven't seen the published papers, but I have seen it work. And he, before he moved back to Denmark, actually wrote us up a little protocol on how to do music therapy at the bedside. And he was incredible during lockdowns. He did Zoom for music therapy, because I don't have a music therapist in Creswick. You know, I'd be lucky if there was one in Ballarat. I haven't seen one. But he was able to do that online to help support the patients, and we saw incredible changes. But even if it's as simple as knowing what someone likes and having that on the radio, that's better than nothing. So yes, I have seen it with appetite. I've seen it with behaviours. I've seen it with pain, and I've definitely seen it with anxiety. Nausea, I'm not sure, but maybe appetite plays into that.
Excellent. Thank you, Claire. Another question is around when there's different cultures, languages, beliefs. Do you have any insights to share around your approach in those situations, or are there any cultural or Aboriginal and Torres Strait Island specific resources that you know of that we could point people in the direction of? Just anything you'd like to share?
Sure. I'm definitely not an expert. I have seen some beautiful advanced care planning resources, Advanced Care Planning Australia, and I think Dementia Australia as well have specific resources for Aboriginal and Torres Strait Islander and for other different cultural groups. And they also have translated resources. There's some very good palliative care resources on Palliative Care Australia's website in different languages. And I believe they have Aboriginal and Torres Strait Islander specific resources as well, and Palliative Care Victoria on their website too. So good to have bookmarked those ones. In terms of different cultural languages and beliefs, my experience has been just ask. You know, just ask and find out what's right, because I've made the mistake. I made the mistake once of making an assumption, because we had an Italian mama, and the family looking after mama, and she had a crucifix, and there was some prayer books and whatever, and I made this assumption that she was a practicing Catholic, and I shouldn't have made that assumption, because she wasn't. And so don't assume, ask. And I think if you ask with genuine curiosity and openness, it's really well received. I remember in the first lockdown, had to take a bed to a family whose mum had advanced dementia and wanted to stay at home for a terminal phase, and took a bed down. And I've learnt much more about putting beds together during lockdown than I have about anything else, I think. And it was really hot, so maybe it wasn't first lockdown, it was early anyway. And I got there and I realised I had short sleeves, very short sleeves. And so the daughter was there and the granddaughter. And before we went in, I just said, is this okay? You know, I can go and find a longer top to put on. I'm just not sure. I want to be respectful. And she said, thank you very much for asking. No, it's okay. It would upset my dad, but he's not here. But thank you for asking. So if you don't know, just ask with openness and honesty and say, look, I'm not sure. I really want to do the best thing I can for you. What are the important things to you? And, you know, note them down. You know, people love that. You know, it's not just, if I'm going to sit with someone in terminal phase, you know, how does mum like her coffee, or, you know, which music does she like? It's also what's important to mum. You know, what would she like, and what information do you need from me to know that I'm safe, if that makes sense.
It does. Excellent. Thank you, Claire. And then one last question we might go to. The question is around when you get to go on leave and have a holiday, how do you go getting another doctor to cover for you, given the vast kind of amount of work that you do? So a curious question from one of our participants.
It's a great question. And if you're volunteering, I'll take you up on that. I've been very fortunate, and I've learned a few lessons from in general practice where we had a buddy system, and my poor buddy got quite overwhelmed, I think, when I did go on leave, is make sure that you have that set up early. So I now, as a solo GP, make sure that the families that I'm being asked to see, I'm not looking for patients, please don't refer people to me, but when I see them, I say, this is my capacity, this is what I can do. And I did go away last year. I did go to a conference and I went overseas. And so I was able to divvy up the people who I thought would have a problem during that time to make sure they had and they knew specialist palliative care connections. I didn't have a lot of GP cover because everyone's really flat out, but there's other ways of having them connected and having preemptive plans. And we had someone, a beautiful lady, looked after the charity for us and manned the phones while we were away. So it's not easy. It's easier when you're in a group practice, I give you the tip, but I hadn't even looked at hiring a locum because I think they'd run away screaming, because it's what I love, but it doesn't mean it's for everyone.
Thank you, Claire, for sharing that. I just saw that there's one more question that's popped up. Are you happy to take one more? Yep, excellent. So this attendee says, often I have residents in aged care with dementia and the relatives or POA, power of attorney, are asked by the staff to do an advanced care directive. What is possible in this instance?
Right, so we're saying that the resident no longer has capacity and the family members asked to fill it out like a form. Is that the question? Hang on, I'll see if I can find it.
I don't have any more detail than that, I'm sorry.
Sorry, Emily, keep throwing you under the bus. Often have residents aged care with dementia. Okay. Yeah, so short answer, it's not quite right, is it? The end point of an advanced care directive is the paperwork. The common law advanced care directive is someone's wishes that has been spoken to you. If you've got someone else filling it out and then having someone else sign it, or having the resident sign it, you might have had lots of discussions. You might feel very comfortable with that advanced care directive. I probably wouldn't feel comfortable. Sorry, phone's dinging. I would say, I'd say that's, in that situation, I'd be asking the staff to give out the what I know about this person's preferences and values form, okay? Not an advanced care directive, because just filling that out means nothing if you haven't had the discussion about what it means. I always believe in the values directives over the instructional, because our options for treatments are going to change drastically over time, whereas our values tend to stay fairly static, usually. So I would say, I think I'd have a look at why that's happening. And I have seen the pressure when people come into it, get admitted to a residential aged care facility, to just get the advanced care plan done, get that piece of paper done, tick, it's off the list, it's done. We know where they want their washing done, we know what their allergies are, and they've got an advanced care directive. That's pointless and will not help you in the middle of the night if someone's got an exacerbation of disease and you're trying to work out whether to transfer them or not. I think that's probably a default to a very stressed and overworked residential aged care facility staff response. I don't feel that comfortable with that. Is that reasonable?
Thank you, Claire. That's great. Look, we might wrap up our Q&A session there. I'd just like, perhaps if we move to the next slide, if that's okay, we have a link to our, oh, sorry, you had one more in there.
It's all right. Find yours, I apologise.
So I think it's the next one, there'll be another link to the evaluation. Please, can you complete that this evening or at your leisure? That would be wonderful if you could do that for us. But I would like to just thank you very much, Dr. Claire, very much for sharing your time and expertise with us all. We really appreciate your contribution to supporting general practice in that palliative care and end of life care planning stage. It's been a wonderful presentation, so thank you very much. And I'd like to thank everyone who is online and who's participated this evening. Please keep an eye out for the next of our series of palliative care focused webinars for general practice, and thank you for your time this evening. We might wrap it up there. Thank you all and good evening.